I'm going to talk about my research on sports participation and patient-reported functional outcome between UKR and TKR in a match control cohort, a 2-year follow-up. So this study was performed in Austria, in Innsbruck, under the mentorship of Professor Christian Fink. As of now, we have nothing to disclose. I'm going to cover this topic on these headings, and let's talk about the background. As many as 20% of patients who have received total knee arthroplasty has isolated medial osteoarthritis, and it could be treated either UKA or TKA. Both the TKA and UKA are effective and offer similar outcome for medial osteoarthritis. And after knee arthroplasty, patients have high expectation, and now these days, success of the arthroplasty more and more judged by return to sports and return to physical activities. Therefore, patient must receive most efficacious procedure for this condition. Our purpose for this study was to compare sports participation and sports activity between TKA and UKA. We also compare the functional outcome between these two groups, and we also want to know the survivorship of the prosthesis in sporty active patients in both the cohort. We hypothesize that both TKA and UKA will have a positive effect on sports participation with similar result. We also hypothesize that similar functional outcome and activity level will be noted. And we believe that prosthesis survivorship will not be deteriorated by sports activities, and survivorship will be similar in either group. For this study, we collected prospectively data from 2010 to 2019. Both the group were matched for demographics such as age, gender, and BMI, and preoperative patient-reported functional outcome that include Oxford knee score, Tegner activity level, and was for pain. After matching, we had 287 patients in TKA and 69 patients in UKA. The inclusion criteria was primary symptomatic medial OA, age between 50 to 90 years, and minimum 2-year follow-up. We excluded the patient who had rheumatoid arthritis, lateral compartment osteoarthritis, and patellofemoral osteoarthritis grade 3 and 4 KL. We also excluded patient who had flexion contracture more than 10 degree, varus deformity more than 10, valgus more than 5, and preoperative range of motion less than 80 degree. We also excluded a patient who had functionally deficient ACL and revision knee surgery. Patients were evaluated at baseline for sports participation and type of sports, and they also evaluated for patient-reported functional outcomes. So after the matching, we had 56 patients in UKA and 280 patients in TKA. For the sample size, we needed 56 patients in UKA and 280 in TKA with 90% of power and significance level of 0.05. And in this study, we had 69 patients in UKA and 287 in TKA. So our power of study was more than 90%. We used chi-square test, Wilkinson sign rank test, and Mann-Whitney U test for the analysis. Now you can see the mean age of the patient was almost 75 years in either group. There was no significant difference between the two groups concerning the demographic variables such as age, BMI, and gender. Significant improvement was noted in the weekly sports participation in either group at final follow-up compared to baseline. All the patients returned to their desired activity. You can see that more than 5 times a week sports participation significantly improved in both the groups. But interestingly, no significant difference was noted between the two groups in sports participation at 2-year follow-up between UKA and TKA. Similarly, Oxford, Tegner, and was for pain improved significantly at final follow-up, and here again there was no significant difference between these two groups for patient-reported outcomes, and also no patient for revision surgery was noted for any reason at 2-year minimum follow-up. So the finding of this study is very interesting because normally we believe that patient who had UKA will have a better sports participation than the TKA group. But this is not a true picture. You can see there are many studies was published and they believe that sports participation will be better in UKA. But These studies were not matched for demographic variable and baseline patient-reported outcome. And it is important to know that in these studies, the patient-reported outcome was significantly worse in TKA than the UKA, and TKA patients were older and had higher BMI than the UKA. And we all know that age is a negative predictor for postoperative activity level. Therefore, and in this study, weekly frequency of sports activity significantly increased after the surgery, and the most common sports activities were hiking, cycling, and swimming in summer, and in winter, skiing, cross-country skiing, and hiking. We also published our paper on the left and right. We look for the sports participation at two-year follow-up and at mid-term follow-up, that is the 5-year follow-up. And all our patients had improved significantly in terms of the sports activities, and they were enjoying their sports activities. Similarly, the Oxford knee score, Tegner activity level, and was for pain improved significantly in both the groups. And this is in the agreement with the previous literature that UKA and TKA will have similar functional outcome. But on the contrary, there are some studies which were demographically matched, and they says that a patient with UKA will have better functional outcome compared to TKA. But again, this is not a true picture. Why? Because in the previous studies, UKA patient had a better functional outcome than the TKA, and we believe that if preoperative functional outcome is better in one group, then postoperatively they are going to work better. Therefore, matching for demographic variable and preoperative outcome is necessary for unbiased comparison of the sports participation and patient-reported functional outcome between these two groups. This study has a lot of limitations. First, it was the retrospective analysis of the outcomes. Both the groups were matched, therefore overall sample size was decreased, and it may cause a selection bias, but we believe that matching will remove all the confounding factors. This study has only 2 years of follow-up. However, so we can really don't know whether the survivorship will be deteriorated over the time. For that, we need a long-term follow-up, and the sample size was small in the UK, but we believe that indication for UK is less than TKA group. However, the strength of studies were that this is, as far as we know, this is the first study where both the group were matched, not only for the demographic variable, but also the baseline preoperative functional outcomes. And this allows us the proper control for comparison and eliminate the confounding factor. In conclusion, traditionally we believe that isolated medial osteoarthritis in these patients, UKA will give a better result than the TKA, but the current study demonstrates that if confounding factor will control, then both are the good procedures. So we have to take individual approach for the patient, and then we'll go forward after the counseling. Thank you very much.